Let me first thank you for your commitment to being a hospitalist educator for the IU School of Medicine. We value your contributions and know the challenges of making time to teach our students and residents, especially during busy inpatient rotations. This video series is designed to be a flexible way to address a persistent opportunity for improvement that we have identified from interviews with our learners. Specifically, our learners need more feedback from us hospitalists. More feedback? Chances are you are already feeling like you give too much feedback. Well, we believe that with some pointers, you will be better equipped and more comfortable delivering effective feedback to your students, and they will be more likely to recognize it. Let's take the next 10 minutes to review how to deliver effective feedback on the wards. I encourage you to pause the video to reflect on your own teaching practices. Think back to your last ward rotation. Were you able to discuss feedback with any or all of your learners? Do you think your feedback made an impact on your students' practice or behavior? Do you think your learner realized they were receiving feedback? With active reflection, a commitment to improvement, and repetition, effective feedback will become one of your skills as a master teacher. So, what is feedback? Simply put, does your student know what you think about them? And I don't mean could they tell if you like them as a person or not. Rather, do they understand what you think they are doing well or could improve on? Unlike evaluation, which we usually think of as a final end-of-rotation assessment or grade, feedback should be a formative, dynamic process including interactive observation and conversation between you and your student, aimed at identifying what they are doing well and should do more of, and what they need to change. If you think about it this way, this is way more important to their development as physicians than the grade they get. It is unfortunate that we refer to giving feedback because if you stop and recall the last time you gave feedback, and if it was a one-way conversation of you telling your student only what went wrong, perhaps you may start to understand why our learners don't always recognize or appreciate the feedback we think we are providing. Next, you need to be aware that there is a hierarchy of effective feedback. The most basic feedback is a simple agreement or disagreement with the learner, which we all deliver often without much preparation, fanfare, or discussion. For example, first-line therapy for a UTI is Bactrim and not Cipro. Next. Pretty black and white. This is good, but does not maximize potential for improvement. The next level of feedback goes a step further by explaining why this was an incorrect choice. For example, while Cipro is a tempting choice, problems with tendon rupture and increasing problems with antibiotic resistance make Bactrim a better antibiotic to start with. You're still telling them the right answer, but now you're giving more context with an explanation they will use to grow their clinical reasoning. The highest, most effective level of feedback incorporates interaction by asking the student to self-assess with an action plan that will help them remember. For example, Cipro would certainly cover an E. coli UTI, but can you think of another antibiotic that would be more effective but avoid fostering resistance and potential tendon rupture? Where would you look that up? Other open-ended catchphrases to encourage self-reflection are, how do you think you did? What would you do differently next time? And could things have gone better? Now that you're aware of what feedback is and the different forms that we use, let's get into how to do it. This may seem like a lot, but chances are you already do a lot of this unconsciously. Again, please pause the video and reflect on any item you might need a bit more time to think about. First, you need to prepare. Unlike simple feedback delivered on the fly, effective feedback requires a little more planning. But just like performing a lumbar puncture, setup is critical to success, and with repetition, it all gets easier. I will not be covering how to set goals and expectations during this video, but I'll say feedback is more effective if your learners have already been oriented to what is expected of them before you give feedback on how well they met them. For example, your student should already know what is expected in a concise and thorough H&P before you critique that H&P. Luckily, your learners probably have access to a course curriculum that was carefully prepared by their clerkship or rotation director containing goals and expectations. You should probably be familiar with these so that you know what you should be teaching them, especially if you have different levels of learners. In addition, some hospitalists like to hand out or email printed expectations for their ward teams, just to be clear. Regardless, it is expected your learners have already been oriented to what they should be doing. Second, you will need to be specific in your feedback, which unless you have an amazing memory, you will need to explicitly plan observations of your learner and take notes. Why? Because vague general comments are generally useless. For example, observing that your student needs to avoid medical jargon with patients will probably not be as useful or memorable as reminding them, avoid the use of medical jargon like myocardial infarction. Another example would be, nice job with our complicated patients. Not as helpful as, you did an excellent job balancing volume management for that complicated cirrhotic patient with hepatorenal syndrome. When vague, your student is not quite sure what you are asking them to fix or continue, although you may think it obvious. Specifics ground your feedback in actionable items for improvement. Also, these are the details that you should try to write in your summative end-of-rotation evaluations. I don't know about you, but unless I take some notes, there's no way I'll remember these details by the time I get around to completing their evaluation. Keeping a little notebook page or note card for yourself, or even emailing yourself with a subject line for the student can help you keep track and are easily pulled together when it comes time for evaluations. Third, you will need to be choosy about timing and location. Dynamic feedback is almost useless if it does not occur at an educational point of care. The chosen location should also accommodate privacy, as constructive feedback can be taken as uncomfortable or even humiliating if done in a public setting. These two items usually require that behavioral feedback, especially if constructive or negative, be discussed in a one-on-one setting at a time when you can break away from rounds. A nook in a hallway is fine, but probably not if the entire team is jammed into it. These do not have to be long observations. Actually, they are better if they are brief, as you don't want to overwhelm your student. For example, you can choose to just observe your student taking a past medical history, or your intern completing admission orders for a patient with community-acquired pneumonia, or your resident leading a portion of a patient-family meeting. But if your only observations are of card-flipping presentations by your student in your team room, or of management decisions your resident tells you over the phone, it may be time to stop and plan how to work more encounters of active observation and feedback into your daily flow. Now that the hard part is done, a few comments as you deliver your feedback. First, do not forget to open with the word feedback. As silly as it may sound, the best way to get your learner's attention for incoming feedback is to say something like, "Let's discuss some feedback." Second, be aware of your tone. People remember how you said something more than what you said. Be mindful to avoid going into attack mode, especially if delivering negative feedback. Consider opening with an open-ended self-assessment question and really try to listen. This does not take as long as you think, and you may be surprised at the answers. Third, try to focus on specific actions rather than personal descriptions. For example, "You were really nice to that patient," is not as instructive as, "I really liked how you sat down to get eye level with your patient and used a calm, comforting tone of voice." If you took notes, this should not be hard. Details, details. Remember to include both positive and constructive, formerly known as negative, feedback. Some of us still use the feedback sandwich of opening with something positive, delivering a constructive, and then finishing with a positive item of feedback. And finally, you need to finish with a plan. With practice, you should always find a way to direct your student to deepen their understanding of what you've just discussed. This may be assigning them to read up to date, to perform an Ovid search, having them prepare a quick 5-minute presentation to the team or to you, or asking them to share a relevant article with the team. Teaching our students how to teach themselves should be a part of any effective feedback plan. Still there? If so, thanks again for taking time to listen and reflect on how we'd like all of our IU School of Medicine hospitalists to be delivering feedback on our ward rotations. If this feels like it is all too much, I strongly encourage you to pick one item to focus on during your next rotation. See what works and what doesn't. Discuss this with your colleagues. Tweak and practice until your new teaching practice becomes second nature before coming back for more. Eventually, you will become effortlessly excellent and you will find new enjoyment in teaching, and your students will thank you for it.